I want you to do something for me right now. Just take a nice deep breath.
Okay.
Go ahead. Fill your lungs. Now, as you exhale, consider this startling fact from the microbiology notes we're doing a deep dive into today. With that single breath you just took, you almost certainly inhaled fungal spores.
Yeah, I mean, it is an unavoidable reality of living on Earth. Fungal spores are just ubiquitous. They're aerosolized in, well, almost every environment we move through.
Right, but the fascinating part of this scenario isn't just that you inhaled them. It's the fact that those spores are completely harmless to you right now.
Yeah.
Like your body's actively clearing them out as we speak.
Exactly.
But under slightly different clinical circumstances, those exact same seemingly inert spores could rapidly become a lethal threat.
And that dichotomy really strikes at the core of what we're analyzing today. We are looking at organisms that live in this state of suspended potential.
So our mission for this deep dive into your microbiology sources is to explore opportunistic fungal infections. We're looking at the chilling intersection of microbiology and immunology, specifically what happens when our immunity fails.
Right. And to frame this properly, we really first have to separate a true or primary pathogen from an opportunistic one.
Because they're not the same thing at all.
Not at all. Primary pathogens, things like histoplasma or coccidioids, they possess intrinsic virulence factors. They are genetically equipped to overcome a robust, fully functioning immune response.
They actively force a breach.
Yeah, exactly.
Okay, let's unpack this. So a primary pathogen is like a skilled burglar who arrives with a blowtorch and lockpicks, fully prepared to break into a secure vault.
Sure.
But an opportunistic fungus is more like a passerby who only walks into the house if you leave the front door wide open.
That burglar analogy perfectly captures the difference in intrinsic capability. Opportunistic fungi just do not inherently possess the enzymatic tools to dismantle a healthy host's defenses from scratch.
They need you to do the work for them.
Right. They rely entirely on an existing breach. So the designation of opportunistic is less a fixed biological trait of the fungus and more a statement about probability.
Meaning, it's just highly unlikely they will ever establish an infection unless the host undergoes a significant physiological shift.
Which introduces a really crucial layer of complexity here. The nature of that physiological shift, how that proverbial door gets left open, dictates entirely who is going to walk in.
Because not every opportunistic fungus can exploit the same immune deficit.
Exactly.
The sources refer to this as immune fingerprints, and it completely reframes how we look at susceptibility. There is no such thing as a generic weak immune system, right?
No, not really. Highly specific cellular defects create highly specific fungal vulnerabilities. It's almost like a lock and key mechanism.
So the notes detail several of these specific fingerprints. And the first one involves profound neutropenia and Aspergillus. Now, the sources mention that Aspergillus spores are found in soil, compost, and even blowing through standard HVAC systems.
Oh yeah, we inhale hundreds to thousands of Aspergillus Candida every single day.
Which makes me question the mechanics here. If I'm inhaling a compost heap's worth of spores daily, and they can cause invasive disease, why aren't we all constantly fighting off invasive aspergillosis?
Well, the reason it doesn't happen is the sheer ferocity of the neutrophil respiratory burst.
The what?
The respiratory burst. When those spores reach your alveoli, the resident alveolar macrophages try to clear them, but the heavy lifting is actually done by recruited neutrophils.
Okay, so neutrophils act like first responders.
Exactly. They swarm the spores and unleash this barrage of reactive oxygen species. They completely degrade the Candida before they can undergo the morphological shift into hyphae.
So it's this relentless microscopic war that your innate immune system just wins, essentially 100% of the time.
Right, until those neutrophils are artificially removed from the equation.
Like with chemotherapy.
Yeah, let's say a patient is undergoing induction chemotherapy for acute myeloid leukemia. That pushes their absolute neutrophil count to near zero for weeks at a time.
And without those neutrophils.
In the absence of that oxidative burst, the inhaled spores just swell and germinate. They grow into long, branching filamentous structures called hyphae.
And the notes say these hyphae do something called angioinvasion?
Yes, which is as bad as it sounds. They physically penetrate the endothelial lining of the pulmonary blood vessels. This leads to thrombosis, tissue infarction, and severe hemorrhage.
Wow. So the fungus literally uses the blood vessels as a highway while simultaneously destroying them.
It does. It's terrifying how quickly a normal environmental exposure turns into a lethal vascular event just by subtracting one specific cell lineage.
Just one missing piece of the innate immune system. But an innate immune failure looks drastically different from an adaptive immune failure.
Absolutely.
Which brings us perfectly to the second fingerprint, T-cell depletion and Cryptococcus neoformans. The reservoir for this one is fascinating. We're talking about soil heavily contaminated by pigeon droppings.
Yeah, it's an encapsulated yeast that really thrives in that highly nitrogenous environment. So urban populations inhale it pretty much continuously.
But unlike Aspergillus, where the body uses that rapid search and destroy tactic, the immune response to Cryptococcus relies heavily on containment.
Right. CD4 T cells orchestrate a granulomatous inflammatory response to wall off the yeast.
So instead of immediate eradication, the immune system just builds a barrier around it.
Basically, the adaptive immune system recognizes the polysaccharide capsule of the yeast. Then macrophages, driven by cytokines from those CD4 T cells, fuse together to form giant cells. They effectively quarantine the organism right there in the lung tissue.
I always think of that granulomatous response like pouring concrete over a toxic spill. You might not completely neutralize the hazard, but you've encased it so it can't leak into the rest of the facility.
That concrete analogy is highly accurate. But the problem arises when the structural integrity of that concrete relies on a continuous supply of CD4 cells.
So if a patient's CD4 count drops,
Specifically below the critical threshold of 100 cells per microliter, yes, the granulomas begin to break down. We see this most prominently in advanced, untreated HIV infection, where the virus systematically depletes that exact T cell population.
the containment fails, the concrete cracks, and the yeast disseminates. And the notes say it has a notorious affinity for crossing the blood-brain barrier.
It does. It migrates directly to the central nervous system, establishing cryptococcal meningitis.
And the global burden of this is just massive, right?
Staggering. It disproportionately drives mortality in sub-Saharan Africa and Southeast Asia. Structural barriers to HIV antiretroviral therapy have historically allowed those CD4 counts to plummet in those regions.
It's just a stark illustration of how a microscopic failure in adaptive immunity cascades into a macroeconomic global health crisis.
Very true.
So we've looked at innate failure and adaptive failure. But the third fingerprint, here's where it gets really interesting. It involves a systemic metabolic collapse. We're looking at mucormycosis.
Often sensationalized in the media as the black fungus.
Right, the black fungus. So how does this one work?
Well, the pathophysiology of mucormycosis is essentially a masterclass in compounding variables. These molds require a highly specific environment to undergo rapid invasive growth.
Okay.
They need highly acidic conditions, and they require massive levels of free iron.
But a healthy human body doesn't naturally provide an acidic, iron-rich buffet.
No, it doesn't. But a patient experiencing diabetic ketoacidosis, or DKA, provides exactly that. The blood pH drops, creating severe acidosis.
And as the notes detail, that drop in pH actually protonates transferrin, which disrupts its ability to bind iron.
Exactly. The transferrin essentially drops the iron it was carrying. This floods the serum with free iron. Simultaneously, the hyperglycemia provides massive amounts of glucose for the fungus to feed on.
So it's basically throwing a feast for the mold.
Yes, but that metabolic storm isn't usually enough on its own. The most devastating presentations occur when you introduce high-dose corticosteroids into that environment.
Because while the steroids are acting as powerful anti-inflammatories, they're actively blunting the macrophages that are trying to fight the mold.
You're simultaneously feeding the fungus its ideal nutrient profile, providing the acidic pH it favors, and paralyzing the immune cells tasked with clearing it. It is a perfect storm.
And we actually saw the grim reality of this mechanism play out recently, right? During the COVID-19 pandemic.
We did, particularly in India. The incidence rates spiked astronomically, tens of thousands of cases.
Because of the treatments being used for COVID.
Yes. The viral pneumonia required aggressive corticosteroid therapy to manage the severe lung inflammation.
Right.
So when that steroid protocol was applied to a population with high baseline rates of uncontrolled diabetes, it created an unparalleled surge in mucormycosis.
The viral insult, the iatrogenic steroid effect, and the underlying endocrine failure all just perfectly aligned.
Exactly.
You know, the word iatrogenic keeps surfacing as I look at these examples. Chemotherapy, massive steroid doses, these specific vulnerabilities seem heavily tied to modern medical scenarios.
Well, that's because opportunistic mycology as a distinct field didn't truly exist prior to the mid-20th century.
Wait, really? We didn't know about them.
We knew the organisms existed, but we didn't have the patients. We systematically created the patient populations these fungi require to thrive.
Wow. The sources map out 3 distinct historical threads that illustrate this. The first is the antibiotic era, of the 1940s and 50s. We mass-produced penicillin to win the war against bacteria.
And inadvertently trigger a massive wave of mucosal yeast infections.
Right. Broad-spectrum antibiotics indiscriminately eradicate the normal bacterial flora on our mucosal surfaces.
Because the gut and the oral cavity are highly competitive microenvironments. The bacteria and the yeast are constantly fighting for real estate and nutrients.
So when you drop a nuclear bomb on the bacteria, Candida, which is just a perfectly normal commensal yeast residing there, suddenly finds itself in a post-apocalyptic landscape with zero competition.
Exactly. It proliferates unchecked, causing oral thrush or severe vaginal candidiasis. It was really one of clinical medicine's first clear indications that merely altering the host's microbiome could transform a harmless neighbor into an aggressive clinical problem.
Now, the second historical thread is much more somber. It places us in post-World War II Europe, around 1952. Two Czech researchers, Vaněk and Jirovec, started investigating clusters of a peculiar pneumonia.
They were looking at institutionalized, severely malnourished infants in orphanages. The organism they identified, Pneumocystis jirovecii, had been observed decades prior, but usually just as an incidental finding in animals.
But the post-war wave in these orphanages established a vital clinical correlation, right?
It did. It showed that profound protein-calorie malnutrition severely suppresses cell-mediated immunity. It turns a silent colonizer into a suffocating pathogen.
And then the third thread accelerates us into the 1960s and 70s, the dawn of aggressive oncology and solid organ transplants.
Right, where we develop the pharmacological tools to intentionally suppress the immune system. We do it so a patient's body won't reject a new kidney.
But physicians immediately began encountering deep, disseminated infections of Aspergillus and Candida in patients with absolutely no prior history of immune defects.
The only common denominator was the deliberate drug-induced neutropenia or T-cell suppression. We were intentionally opening the door to save the patient's life, and the fungi were just walking right in.
It's wild to think about.
Yeah.
But the concept of the opportunistic infection didn't truly hit the public vocabulary until 1981. It was because of a specific publication in the CDC's Morbidity and Mortality Weekly report.
Yes, Dr. Michael Gottlieb's report. It detailed 5 previously healthy gay men in Los Angeles presenting with pneumocystis pneumonia.
An infection that, as we just established, essentially required a completely collapsed immune system, like the starving infants in 1952.
Exactly. So finding it in young, otherwise healthy individuals was a massive blaring siren for the medical community.
It was the opening salvo of the AIDS epidemic. Overnight, understanding these obscure fungal opportunists became a critical necessity.
What's fascinating here is the taxonomy failure surrounding pneumocystis.
Oh, yes. For the vast majority of the 20th century, the scientific community classified this organism as a protozoan-like, a parasite.
It lacked ergosterol in its cell membrane, which is a hallmark of fungal cells, and it didn't respond to any traditional antifungal therapies. So morphologically, under a microscope, it appeared protozoan.
That's like misfiling a deadly shark in the bird section of the encyclopedia for decades.
It really is. The clinical inertia behind that classification was immense. It wasn't until 1988, deeply into the AIDS epidemic, that Edman and his team sequenced its ribosomal RNA.
They published the findings in Nature, right?
Yes, and definitively proved it was a fungus. Misclassifying an entire kingdom of life for decades, especially one causing such massive mortality, must have been a staggering realization.
The clinical fallout must have been significant.
Oh, totally. Because it was misclassified, the pharmacological approach was entirely skewed. Discovering its true phylogenetic lineage eventually helped explain its atypical drug resistance.
Though the notes say even today, we treat it with antibacterial sulfa drugs rather than traditional antifungals.
We do, due to its unique membrane composition. But reclassifying it was a massive paradigm shift.
Well, if the scientific consensus could misfile something that critical for that long, it forces you to look at where else the rules are failing us. Because fungi don't always neatly adhere to the rigid categories we've built.
No, they certainly don't. The boundary between opportunist and primary pathogen is heavily blurred.
Yeah, particularly when you look at the 1999 Vancouver Island outbreak.
That Cryptococcus gattii outbreak forced a complete rethink. For decades, C. gattii was taught alongside C. neoformans as a standard opportunist. But in 1999, dozens of immunocompetent, completely healthy people in British Columbia began presenting with severe cryptococcal pneumonia.
The passerby decided to break down a locked door.
Exactly. The investigation revealed that host immunity was only half the equation. The other half is ecology and inoculum size.
So what was the ecological factor there?
C. gaty had established a highly specific environmental niche in the region's eucalyptus and Douglas fir trees. Logging and environmental disruption aerosolized massive quantities of the yeast.
If the exposure dose is astronomically high, the baseline competence of the host's T cells just becomes irrelevant.
Right. The sheer volume of the pathogen overwhelms the containment strategy. It demands that clinicians expand their diagnostic algorithms. You can't simply identify an unusual fungal pathogen and assume an occult immune defect.
You have to integrate environmental exposure, geography, and ecology into the patient's history,
You have to.
which complicates an already brutal diagnostic and treatment landscape. The sources detail the historical pharmacological options, highlighting a drug with arguably the most descriptive nickname in medicine.
Yes, amphoterrible.
Amphoterrible. The actual name is amphotericin B deoxycholate. But why was it so terrible?
Well, for an agonizingly long period, it was the only reliable broad-spectrum fungicidal agent available for systemic disease. It works by binding to ergosterol and tearing pores in the fungal cell membrane.
Okay, so it kills the fungus,
Yeah.
but the collateral damage,
Yeah.
the toxicity profile sounds like a nightmare.
It was severe. Patients would experience violent infusion reactions, intense rigors, fevers, while the drug simultaneously caused massive, sometimes irreversible nephrotoxicity.
Kidney damage. So clinicians were trapped in this horrific calculus, weighing certain death from invasive candidiasis against the deliberate destruction of the patient's kidneys.
It was a nightmare trade-off. But the pharmacological landscape did eventually evolve. The development of lipid formulations in the 1990s revolutionized the use of amphotericin.
How so?
By packaging the active molecule within a liposome, the drug was preferentially taken up by macrophages right at the site of infection. This drastically reduced the free drug concentration in the kidneys.
A brilliant workaround, and the arsenal expanded from there, right?
Yes, the triazoles, like voriconazole, proved highly effective against Aspergillus in landmark trials in 2002. And the echinocandin class emerged to target the synthesis of beta-glucan in the fungal cell wall.
Offering a much safer toxicity profile.
Much safer. But having safer drugs is entirely useless if you can't deploy them in time. Culturing fungi from blood or tissue can take days or even weeks.
Which is time a neutropenic patient simply does not have.
Exactly. So the shift toward non-culture-based diagnostics has fundamentally changed survival rates.
Assays that look for galactomannan or beta-D-glucan.
Yes. These assays detect specific carbohydrate antigens from the fungal cell wall that get shed into the patient's bloodstream during tissue invasion.
So they act as an early warning system.
Right. They can turn positive days before a culture might grow anything. Organizations like the EORTC and the MSG have built these really sophisticated consensus criteria, heavily leveraging these biomarkers to initiate preemptive antifungal therapy.
That's incredible progress. But I want to pivot here to address a persistent, frustrating misconception that's heavily promoted online. The sources touch on it, but it's everywhere in wellness spaces. Candida overgrowth syndrome.
Oh, the internet diagnostic trend?
Yes. You find these extensive checklists, fatigue, brain fog, sugar cravings, and the conclusion is always that you have a systemic Candida infection requiring a highly restrictive diet and expensive supplements.
It's incredibly frustrating for clinicians. It distorts the severe clinical reality of invasive fungal disease into a catch-all for generalized malaise.
It takes a legitimate physiological concept, commensal overgrowth, and just dangerously misapplies it.
Exactly. True invasive candidiasis requires a profound structural or immunological breach. We are talking about a critically ill ICU patient with a central venous catheter that physically bypasses the skin barrier.
Delivering the yeast directly into the vascular system.
Right. Or an oncology patient with absolute neutropenia following induction chemotherapy. It is a life-threatening septic event.
Not something you diagnose via a web quiz because you feel sluggish after eating bread.
No, not at all. Real invasive fungal infections possess mortality rates that rival or exceed severe bacterial sepsis. They cause devastating tissue necrosis in the lungs, abscesses in the brain,
It's highly lethal.
blurring the line between localized, superficial issues like athlete's foot and deeply invasive opportunistic fungi fundamentally misunderstands the lethality of the pathogens we're discussing.
And understanding that high lethality rate makes the current epidemiological trends deeply unsettling. Because the demographic of vulnerable patients isn't shrinking, is it?
No, it is exponentially expanding. We are navigating a profound medical paradox right now. The population susceptible to these infections is growing precisely because our medicine is getting better.
The irony of medical progress.
Yeah.
We cure the incurable, but in doing so, we create the perfect host for the opportunist.
Yes. We have millions of patients managing autoimmune diseases with highly targeted biologic drugs, which deliberately blunt specific inflammatory pathways.
And expanding cohorts of cancer survivors.
Right. People whose hematologic malignancies were cured by CAR T cell therapies that permanently altered their immune repertoires. Plus, we perform thousands of solid organ transplants annually, which mandates lifelong pharmacological immune suppression.
We are systematically, deliberately opening millions of doors, and as we create this unprecedented population of immunocompromised hosts, we are simultaneously watching the rise of fungal superbugs.
Yes. If we connect this to the bigger picture, the emergence of Candida auris is terrifying.
The sources note it was first isolated from a patient's ear in Japan back in 2009.
And since then, it has rapidly become one of the most urgent threats monitored by infectious disease agencies globally. Unlike Aspergillus or Cryptococcus, which are acquired from dirt or trees, Candida auris is highly adapted to the healthcare environment itself.
So it spreads efficiently from patient to patient.
It colonizes the skin and contaminates hospital surfaces, bed rails, monitors, catheters. It forms these persistent biofilms that just resist standard decontamination protocols.
Combine that transmissibility with the fact that many isolates are resistant to multiple classes of our best antifungal drugs.
And you transition from managing an individual opportunistic infection to fighting a systemic, hospital-wide outbreak of a multi-drug-resistant superbug in your most vulnerable wards.
It's a daunting reality. We have traversed an incredible amount of clinical territory today, from the innate failure of neutropenia to the ecological surprises of Vancouver Island and the rising threat of resistant superbugs.
That's a lot to take in.
But the underlying through line in these microbiology notes is clear. The fungi themselves haven't orchestrated some master evolutionary plot to become more aggressive.
No, the organisms are merely executing their inherent biological programming. The variables that have changed are the hosts.
Right. To understand the infection, you must analyze the specific structural or immunological deficit. You have to match the defect to the fungus.
A central line breach invites Candida. A drop in CD4 cells unleashes Cryptococcus. The absence of neutrophils paves the way for Aspergillus.
So what does this all mean for you? As we wrap up this deep dive, let's go back to that deep breath you took at the very beginning. You inhaled spores, and your intact immune system dismantled them without you ever even knowing.
A silent victory.
But consider the paradox we've uncovered today. The very medical miracles saving our lives. Broad-spectrum antibiotics, complex organ transplants, highly targeted immunotherapies are exactly what opened the door for these ancient opportunistic fungi to finally take root.
It really makes you think about the future of clinical care.
It does, which leaves you with a deeply unsettling question to ponder as we continue to push the boundaries of modern medicine. In our relentless drive to suppress the immune system in order to cure incurable diseases, are we inadvertently locking ourselves into a permanent, escalating arms race with the very dirt we walk on?